So when you're evaluating someone for the first time, you want to be able to know in the first 10 minutes or so, get an understanding of how severe of a condition are we dealing with and what is that going to lead to in the hospitals? What can I expect and what can I plan for and what can I help prevent? Somebody with blood alcohol level 350, you're assessing them 12 hours later, the CIWAs are rising. What are we doing? We're not going to just be like, oh, the nurse will come reassess you in 4 hours and we'll dictate what's going on. We want to intervene now. The standard of care is to use long-acting benzodiazepines for the treatment of more severe symptoms. If you're switching over to phenobarbital, you don't really want to combine it with other sedatives because that increases risk for respiratory depression, for sedation, and it will then complicate kind of what you're going to be doing management-wise with your phenobarbital as well.
Hello, and welcome to the Transformed Minds. I am so excited to have you here. At the Transformed Minds, this is the podcast where we are exploring the real-world intersection of mental health, addiction, and transformative care. I'm your host, Dr. O, and again, we are excited to have you back with us for season 2. Oh, I can't believe we're here. With each episode, we take a thoughtful, practical, and evidence-informed look at how we can improve psychiatric and addiction care, from our clinical settings to the community spaces. If you're new here, here's the vibe. We have the host RX. It's just me and you, breaking down the research and sharing what really matters. Then we have our Lived RX. That's where real life stories comes in, guests who have lived it, they've survived it, and they're reshaping the system because of it. We also have our Expert RX, where we bring in the brilliant minds from the field, whether it be a clinician, a physician, a scientist, researcher, a change maker, policymaker, any expert in the field of mental health, addiction, psychiatry, we bring them in. And today, we are so happy to have someone whom I have had the privilege to train with, to learn from, and I have been in awe just watching her teach and care for people. And I looked and I was like, why not ask her to do an episode so people could see how awesome she is, especially for people like myself who love to learn. So please help me welcome the amazing Dr. Desai.
Thank you so much for having me on this podcast. I'm very excited to be here.
Oh, I'm so excited to have you. So let me tell you a little bit about Dr. Desai. Dr. Desai completed her residency in family medicine and community health at Robert Wood Johnson Medical School, and she completed her fellowship in addiction medicine at the Icahn School of Medicine at Mount Sinai. She joined Staten Island University Hospital as the Addiction Medicine Consult Lead for the Consult for Addiction Treatment and Care in Hospitals team, our CATCH team. And if you're not aware of what a CATCH team is, it's the model that she's going to tell us about, and I'm excited for that. She enjoys working with patients with substance use disorders and co-occurring psychiatric conditions, utilizing motivational interviewing focused techniques. In addition to her clinical work, she is passionate about interdisciplinary education and teaching medical students and residents like myself in advocacy and policy work for addiction care on a system-wide level. So if you heard anything I said about her, you would know why she's here. Because everything that we've done so far, if you listen to us, you know we're all about substance use disorders and co-occurring psychiatric conditions and how we can make this better for you, for our communities, for our healthcare system, for everyone that needs this care. Today's episode is going to be a little different from what we usually do. Because if you heard what I said, she is so passionate about teaching, especially medical students, residents, and communities. So today she is here to teach us. So I'm going to be doing a lot less talking. I'm not talking at all. She's going to be teaching us from one topic to the other. So if you would please learn your ears with me, I'm going to hand over to Dr. Desai, who will introduce herself, tell us a little bit about CATCH, and we're going to go right into our first substance that we will discuss.
Awesome. Thank you so much. So As you heard, I do work on what's known as the CATCH team. So the CATCH team is an interdisciplinary model for addiction treatment and care. And it's primarily based as an inpatient treatment model. And the reason that is because we are starting to find, or we were finding in the past, that we were doing sort of an inadequate job in addressing the needs of patients who are admitted to the hospitals and caring for not only their addictions, but their co-occurring medical conditions, as well as their co-occurring psychiatric conditions, and having a disconnect in bridging them to the next step post-hospitalization as well. So what the CATCH team is a combination of 3-person models, or 3 types of clinical cares in the hospital. So one is the medical professional. So that is myself, either a physician. Oftentimes we may have ACPs as well who lead CATCH teams, along with either a licensed mental health expert. So that's an LMHC, somebody with a master's degree in mental health and counseling, as well as a clinical social worker. So it's a licensed clinical social worker who's able to do similar counseling, as well as be able to diagnose and provide treatment referrals, both inpatient and outpatient. Along with our clinical teams there, we also have a peer recovery advocate. And so this is that third trifecta model of care. Peer recovery advocate is somebody with lived experience in addiction, who has had a certain amount of time sober, who's done specialized training on how to help patients bridge that gap, and are able to help us communicate with patients in a better level, but also help us understand what the patient's going through at a more deeper personal level, and being able to break down those walls of stigma and being able to build that wall of trust that sometimes is that biggest barrier to advanced care. So this is the team that I lead in the hospital. A big part of our job is seeing patients with these complicated conditions. Substances often don't come in silos. We will have patients with multiple substances going on at the same time, but also everyone's personal experience is a little bit different. And their levels of complexity are different too, based upon their previous experiences, based upon medical conditions or psychiatric conditions that they've come from in the past. And that does impact their current care. And because I'm a consultant, I primarily engage and interact with patients on the inpatient level, meaning everything is pretty acute with care, whether it's an actual acute care setting, such as the emergency room or critical care unit or a medical surgical unit. We are engaging with patients who are at their most vulnerable in some settings, coming to the hospital at their sickest. So this is where our team becomes very crucial and integral in helping to advance some of this care moving forward. And like Dr. O was saying, we do see quite a number of different substances, and we treat quite a number of different substances. So I think one of the first ones that I will often train early learners with medical students, but also our advanced learners with residents, and not just management of alcohol withdrawal, but also figuring out how do we manage complicated withdrawal, which is one of those things that comes up often and can be pretty scary sometimes, especially if you've not done it as often. One of the first things we kind of look at, and one of the things that is integral in doing an accurate psychiatric assessment, but also an addiction assessment when we're talking about patients with substance use disorders, is when we talk about alcohol, we want to hit on a few key points to help us bridge an overall risk pattern for our patients. So when you're evaluating someone for the first time, you want to be able to know in the first 10 minutes or so, get an understanding of how severe of a condition are we dealing with, and what is that going to lead to in the hospitals? What can I expect and what can I plan for and what can I help prevent? And so one of the things that we will often ask about is those 3 big red flag sort of findings. And then we're going to expand on not just those 3, but also some of the other things that we look for and are concerned about. Everyone knows what is the most severe complication we deal with in the hospital when it comes to alcohol withdrawals: seizures and DTs. So we definitely want to be able to assess for both the presence of recent seizures or past seizures. When was the last time that they had a seizure? We want to assess for delirium tremens. And sometimes you will ask your patient, oh, have you ever had DTs before? That will go over a lot of patients' heads. They'll be like, what is a DT? What does that even mean? That means nothing to them. Sometimes you can reframe it and say, have you ever been hospitalized in an ICU setting for alcohol withdrawal? Have you ever been hospitalized, period, for alcohol withdrawal? And that gives you a snapshot too. Because if they say, oh, yes, I was hospitalized once every 3 months. And not only would you have maybe found some of this in your own chart review or clinical care shared network, if you have certain EMRs that are able to access other portals. But also, if you don't have that information, then we need to figure out, where was this patient going for the most time? Why aren't we capturing it? What are we missing? And so sometimes people will look at psyches, if they have Medicaid, and you'll be able to get a sense of how often, if someone's been hospitalized, where they've been hospitalized, and maybe some other information that's readily available there. So now we have a framework for at least history of hospitalizations, DTs, seizures. Not only is that helpful, we also want to assess for things like blackouts. How much is someone drinking so that they are becoming not only intoxicated, but completely having unconscious episodes secondary to how much they're consuming? And sometimes it's hard to gauge. Like, if someone is telling me I'm drinking a pint of vodka a day compared to a liter of vodka a day compared to a handle of vodka a day, now we're increasing the amount that someone is reporting to us. But a lot of the literature does show us that the amount one consumes doesn't always correlate with the severity of what we see. And so that discrepancy between how much one's consuming and the severity can help be bridged by assessing for some of these big red flag things that occur to our patients, the consequences that we're dealing with. And so blackouts are one of the things that we will assess for. That'll give you a good idea of one's tolerance for binging, and each person's individual tolerance is different. But if they're reaching to these levels where they are blacking out, we've hit a threshold. And so those are things we want to look at. The other things we also want to gauge with assessing a risk profile is also looking to see if somebody's had previous neurologic injury or insult. And that's one of those big things that we will sometimes miss and we will not ask about as frequently, but it's one of those things that is really important in understanding how sensitive our patients may be to medications we may give them, and also for complications that can arise. And so for things like that, I'm talking about, have they had stroke in the past? Have they had a traumatic brain injury in the past? Have they fallen and hit their heads? Those things are important to assess. If your patient has had a seizure, you also want to make sure there's been some level of brain imaging done. First episode seizure event should have its full seizure workup. We don't want to pigeonhole our patient with their first episode seizure and miss other things that could be contributing to the seizure. Because when not patients, but when people in the hospital will see somebody with history of alcohol, it sometimes automatically becomes funneled into one line of care and one line of treatment. And we will miss some of the other things that could be occurring. So those things are important. So establishing that clinical risk pattern with some of these neurologic-based complications, but also seeing some other medical-based complications. So if your patient has severe liver injury, does your patient have history of severe fatty liver disease? Does your patient have history of cirrhosis? Does your patient have history of other endocrine or psychiatric related complications that are active? Is someone presenting with active hallucinations or delusions? Is someone presenting with an active toxicity level, whether it's from their thyroid medication, whether it's from their psychiatric medication, whether they are having acute hepatitis based on the rise of certain levels with our liver enzymes? Is the function of the liver even working? Are we dealing with certain patterns with our MELD score, with our Child-Pugh score, with our FIB-4 calculations? Are we dealing with complications where we're now thinking about, okay, we are dealing with someone who's of advanced risk with some of these medical comorbidities? Those things are going to be helpful for us as well to help us paint a clinical picture. So those are some of the things that help us kind of get a framework. And the reason why this is important is because when we're evaluating somebody for alcohol withdrawal, we want to be able to have that foundation, but now then we're talking about, what do we see bedside? So if you're evaluating a patient and your patient is already having a clinical alcohol withdrawal scale of at least 8, maybe more than that when you're first evaluating them, you want to get a sense of what already has been done. Have they received doses of medications in the emergency room prior to you evaluating them? Or in the critical care, so wherever you have been, wherever you're treating them. You want to see, what have they received in the last 24 hours that they've been here? Is the trend going that their scores are getting worse? Because CIWA is a clinical documentation that's done by nursing. We want to do our own clinical assessment bedside. It's good practice to get your own assessment of what's going on when you first lay eyes on your patient, because that helps back up what your plan will be. So see how many medication doses they've received. If your patient has a CIWA score of 8, they were just admitted overnight, and you're seeing that they've received already 50 milligrams of diazepam overnight, and you're seeing them and things are not necessarily getting better based on your clinical impression of how the CIWAs have been trending, then maybe it gives you an idea of what you might need to be doing moving forward. And we have multiple approaches for this. And not one treatment approach is necessarily superior to another, but the reasons we choose between these options help us try to, essentially, we want to mitigate some of these high risk factors that one may have previously experienced before or could experience in the future. If my patients had a seizure in the last year, or they were just hospitalized 6 months ago for DTs in the critical care unit, then I already have an idea of kind of the risks that someone could experience. We do know with alcohol that there is a phenomenon called the kindling effect that happens when somebody goes through something like a seizure episode. It lowers their threshold for a significant episode like that again when someone goes through withdrawals. So those are things that are going to be helpful for us in helping us kind of be appropriate with our treatment management. And we have multiple frameworks for how we do this. So one of the first things that we do know that's standardized across all hospital systems is sort of our symptom-triggered protocol. That is a protocol that's done on a hospital-wide level where you can actually control not only the intervals that someone gets screened for alcohol withdrawal questions, right? And the screening questions are these are orders for nursing that you will dictate, and you say, I would like the CIWA to be done every 1 hour if they're in a critical care unit, every 2 hours if they're in a step-down unit, every 4 hours if they're in a med-surg unit. And based on that score, these are the things that could be given to your patient. So for a lot of patients, if a CIWA score is somewhere between 8 to 15, I can dictate an X medication dose and the type of modality, like whether it's OPO, IV, IM, right? I can dictate what that is that the nurse can then administer. Doses can also be dictated for CIWAs that are beyond. So for even more severe risk. So if someone's CIWA is greater than 15, greater than 20, I can dictate this medication that could be given afterwards as well. So these are symptom triggered. So only given if this patient is appropriately scoring on the clinical alcohol withdrawal scale to a certain level. And this can be helpful, especially for somebody who may not have had severe complications in the past. Can be helpful if your patient was hospitalized recently, for example. We will sometimes see patients, have high recidivism rates where they do come back to the hospitals due to multiple social factors that sometimes play into why things aren't getting better outside of an acute care setting. And so if that's the case and your patient was hospitalized within the last few weeks and you did do a significant intervention at that time, and they're telling you they were only able to stay sober for a week and they come back to the hospital 2 weeks later, perhaps someone like that may be okay with a symptom-triggered protocol. But again, these are things that are going to be ongoing assessments. These are not just sort of set it and forget it models. And I think that's the key here that we have to take away is that once we decide on a treatment plan, that doesn't need to be the treatment plan moving forward for the next 5 days of their hospitalization. That this is a daily and sometimes more than a daily reevaluation. And so that's one approach. And symptom-triggered protocol is widely studied, is widely accepted, is probably the primary modality of approach for somebody with mild to moderate alcohol withdrawal symptoms, because we have seen that it decreases the length of stay for hospitalizations, decreases the total number of benzodiazepines that one receives during the hospitalization, and has been safely studied. That is one approach. We then have to worry about our patients with more of these high-risk characteristics and the different approaches that we deal with when we're talking about patients with higher risk complications. So if your patient, you evaluate them, the same patient who was admitted less than 24 hours ago, has had a seizure recently, has had a DT episode 6 months ago, something along those lines. You're seeing them, their blood alcohol level 12 hours ago was 350. You're now assessing them 12 hours later. There is actually a good chance that they would still probably test positive on a blood alcohol level 12 hours after. And you see them and their CIWA's 15. That's not a good prognosis at all. The CIWA's still rising, and it's not even mild, but moderate to severe levels at that point with the CIWA score. And somebody has still positive blood alcohol level. There is a good chance things are going to get worse from there. It only makes sense. Your body's processing the alcohol. We're now dealing with the GABA agonism, and now we're seeing a rise in the glutamate. That is sort of the physiology of alcohol withdrawal that happens. It's this imbalance that we're dealing with. And so why do we fear glutamate surges? Glutamate surges lead to the increased adrenergic drive. All of our neurotransmitters that are activating will start going up. And with that comes things like seizures, DTs, in that order, seizures, DTs. When do seizures peak in the hospital? They peak somewhere around 12 to 24 hours, can extend to 48 hours in some situations, in some cases as well. And when do we start seeing a rise in DTs? DTs we get more concerned about starting around after 48 to 72 hours. That's when we start thinking about DTs. And so somebody with high risk factors already at place, we want to be able to clinically monitor them for about 48 to 72 hours at a minimum, I would say, in some situations, in order to kind of safely say that we are not dealing with things that are going to get worse, and that you have enough time to appropriately and adequately address what's going on and prevent some of these high risks. Somebody with blood alcohol level 350, you're assessing them 12 hours later, the CIWAs are rising. What are we doing? We're not going to set it and forget it, symptom trigger them. We're not going to just be like, oh, the nurse will come reassess you in 4 hours and we'll dictate what's going on. We want to intervene now. The standard of care is to use long-acting benzodiazepines for the treatment of more severe symptoms. If our patient is 50 years old, LFTs are maybe twice normal. We have somebody who otherwise has normal renal function, cognitively intact, not hallucinating, vital signs, slightly hypertensive, not necessarily tachycardic. We're not quite dealing with a delirium tremens picture yet. We're dealing with alcohol withdrawal. And so one approach is to consider front-loading medications. So that means you could give multiple doses of long-acting benzodiazepines consecutively. And that could mean something like a diazepam. That could mean something like a chlordiazepoxide, Librium. So one of these two modalities would be quite appropriate to give your patient. If they're able to take orals, you can choose between both options. If your patient's nauseous, vomiting, they're not going to be able to most likely tolerate an oral Librium. So you may want to give them an IV diazepam equivalent. And so that would be kind of your clinical decision-making right there. And so the doses vary. You can go from doses from 5 milligrams to doses up to 20 or more in one push for alcohol withdrawal. You want to be able to kind of assess a specific dose and then reassess. If you're somebody who's comfortable managing this because you've done it again and again and again, you may feel more comfortable giving your patient a dose of 15 milligrams now and then reassessing in a few hours. The diazepam I would have given would have been, reached, and I could reassess in an hour. If I know that the dose I gave him or her was appropriate, then I could reassess even later than that. So an hour to 2 hours, and then kind of go from there if I need to do additional pushes. So the front-loading approach is doing higher doses of long-acting benzodiazepines up front, and then kind of doing a reassessment approach. The reassessment approach could be one of two sort of ways. We could do a fixed dose taper, a model where you dictate every 4 hours or every 6 hours an X amount of benzodiazepine, and then basically decrease the total daily dosages of benzodiazepines over the course of, could be anywhere from 3 days to 5 days to more complicated withdrawals that might land you to 7 days, something like that. And again, these are daily reassessments. Or you could do a front-loading approach and then maybe do symptom triggered. But it would depend on the case that's in front of you. If your patient comes in and they were just recently intoxicated and now starting to withdraw and having all these symptoms that are going on, if you really wanted to, you could reassess the next day and decide, I front-loaded them. And you can see, okay, if I put them on CIWA and then I reassess, if I'm seeing that the patient has utilized an X amount of benzodiazepines overnight, and it was a significant amount, that they were requiring it every 2 hours or they were requiring it every 4 hours or so, and they haven't kind of missed a dose, and they've been kind of going not much better with their vital signs, not much better with their CIWA scores on reassessment, and perhaps the symptom-triggered assessment is not enough GABA agonism activity that we need at that time. And then you may decide maybe a fixed dose regimen might be more appropriate for this person. So those are some of the clinical decisions that we go through in our head when we decide on what treatment modality to utilize for our patient up front. And again, this is a variable, sort of flexible sort of decision, and it changes per person that's sitting in front of you. And I may choose to do a front-loading symptom-triggered approach, but someone else may choose to do a fixed-based taper. The important thing is that we need to be able to reassess the symptoms and address the symptoms and not let this sort of prolong and go on for days where we're not seeing clinical improvement in the patient's symptoms. And I think that if we wait, that's when we start dealing with these complications. And so that is what we don't want to happen. Then we get to the patients who we know if they've already had some of these high-risk episodes that have happened in the past, I may decide to go straight to a fixed dose regimen up front. And from that point, I can decide, okay, if I'm going to put you on a high-dose fixed dose regimen up front, I can reassess what you'll need after 24 hours. And they don't necessarily need to be on the highest possible doses in 24 hours. If their symptoms are better controlled, I can then decide to go down on the doses and then continue to taper. So it's one of those ongoing assessments that needs to happen. Sometimes the way we expect the course to be dictated doesn't always happen. Sometimes our patients will have their first DT episode, things we don't want to happen. And so we will need to then intervene and decide how much more to increase the regimen from that point onwards. And I think that one of the goals of treating alcohol withdrawal is that we are scared to utilize medications. We want to do it safely. But if someone is being set into a critical care setting, we already have a little bit more of that safety because now they're in an acute care setting that one of the biggest things we worry about with benzodiazepines is excess sedation. And then that fear that the sedation along with other medications could impact their respiratory capabilities. And so if they're in a critical care setting, that allows us a little bit more ease in order to dose medications as well. And that is appropriate. If someone's requiring medications every hour, we worry about the effects of dose stacking of long-acting benzodiazepines as well. And we're in a setting where we are able to safely do that and have the capabilities to intervene if something needs to happen. In a critical care setting, when we're using long-acting benzodiazepines for the treatment of alcohol withdrawal, if someone's on a high-dose taper and still not working, we have kind of a couple of modality approaches that we use. And so these are our complicated alcohol withdrawal cases. One of the things we want to think about when we're dealing with complicated alcohol withdrawal is, are there other sedatives on board? And that's something that you would do anyway with the comprehensive psychiatric assessment, a comprehensive addiction assessment. You want to rule in, rule out all the other substances that could be at play, and also the medical comorbidities that could be at play as well that could decrease one's metabolism of benzos as well, and other sedatives. So those are things that we want to be considerate of because that can help us take a regimen moving forward as well. So if somebody has complications with delirium tremens in the hospital, we're seeing elevated heart rates, we're seeing hallucinations, we're seeing agitations where someone's trying to get up and out of bed, things like that where their RASS score is very high in a critical care unit. The goal at that point is to provide enough sedation where somebody is able to be sedated, but be able to be awoken to verbal stimuli. And that's the level of sedation we aim for with severe alcohol withdrawal. When we have somebody on a high dose benzodiazepine taper regimen, we could go up on the doses of medications. We can decrease the intervals that we give the medications. So a couple of different options here. We can also think about, okay, if somebody has received a significant amount of benzodiazepines in the past 24, 48 hours, we're not seeing clinical improvement. One of the other modalities that we're starting to use now a lot more, especially in critical care settings, especially in emergency settings, is phenobarbital. So phenobarbital is a barbiturate. It has a different modality of action than benzodiazepine. We know benzodiazepines are GABA agonists. And so, yes, phenobarbital does have GABA agonism activity. It does this slightly differently than benzodiazepine, but it also is a glutamate antagonist. And so the glutamate antagonism effects of phenobarbital and other barbiturates, but particularly phenobarbital studied for alcohol withdrawal and complicated combined sedative hypnotic withdrawal, is helpful because it helps us kind of mitigate some of the excitatory findings that we will see when we're dealing with things like delirium tremens. And so for somebody with recalcitrant alcohol withdrawal, unresponsive to benzodiazepines, somebody with combined sedative use, alcohol benzos, alcohol Z drugs, and in some settings, one can argue and maybe find it beneficial to be used with combined sedative hypnotic withdrawal as well, which is often less predictable than alcohol withdrawal. We would think about something like phenobarbital. And so when we make that clinical decision to kind of think about utilizing phenobarbital or switching to phenobarbital, it is something that has to be done in a controlled environment where we have that sort of respiratory support. So in a critical care setting, in a emergency setting, we want to be able to look at somebody's high risk factor. So phenobarbital is incredibly long acting. It is much longer of a half-life than our long acting benzodiazepines. So those are things to consider because it does cause significant central nervous system depression. Not only that, it also causes respiratory depression, which is why we want to be in these acute care settings. We want to assess for hypotension risks. We want to assess for bradycardia risks. But because it also affects or is metabolized by the liver, we do want to assess for significant acute liver injury to see when it might not be safe enough to do that. So these are some of the things that we want to think about. It may not be the best approach for somebody with significant hepatic encephalopathy. If somebody has decompensated cirrhosis, it may not be the best approach. And then it's not that well studied in pregnancy either, so we want to be able to think about not utilizing phenobarbital in our patients who are pregnant. Phenobarbital is dosed with a weight-based model. So what that means is that we would do a milligram per kilogram dose. It is done that way so that we can then decide how we split up the medications. Most hospital systems, especially now with the sort of rising need of utilizing additional modalities to treat alcohol withdrawal and complicated withdrawals, have a phenobarbital protocol. So at the hospital system that you're currently working at, I would encourage you all to explore what your own phenobarbital protocol is. And there's a good chance that there is one in the critical care setting. If there isn't one, they're probably working on one. And so at my institution, we have a phenobarbital protocol, which is nice because then it gives you some safety standards that your hospital has already agreed to, but also gives you clinical flexibility on navigating what could you do next in the event that things aren't going exactly how you expect them to, right? And so that's what we would want from sort of a hospital protocol that's been outlined to deal with some of these complicated cases. And so, like I was saying, it is a weight-based modality. For patients who have complicated respiratory, neurologic, liver issues, things like that, if you've already made the clinical determination to utilize phenobarbital, you can decide that, okay, my patient has a couple of these high-risk categories that maybe going to the highest mg per kg dosage is probably not the most logical thing to do. That maybe I would think about going to one of the more conservative dosages. So perhaps a 5 milligram or 10 milligrams per kilogram dosage. Some hospital protocols will also allow for 15 and 20 milligrams per kilogram dosages. And so based on the protocols at your hospital and the levels of high risk factors that your patient has, you can decide on the appropriate milligrams per kilogram dosage. And there's really no bad choice in choosing a lower threshold, like a lower milligrams per kilogram dosage, and then deciding to do more if you need to. You won't be able to take medications away, but you can always add more. And that's important to take away as well. With that milligrams per kilogram dosage, often what is done is that we do something called a loading dose with phenobarbital. And so you have your total milligrams per kilogram. So let's say, my patient has a total calculation of, if we're doing 10 milligrams per kilogram and they're 90 kilograms, then I have a total of 900 milligrams as a loading dose. That 900 milligrams is divided up according to my institution's administration standards that pharmacy has helped us work with, is dividing it up into 3 doses. And these 3 doses are given every 3 hours. So I have 900 divided by 3, so I will have 300 milligrams every 3 hours. And the goal of that is that because it, like I was mentioning, it is very long acting of a medication, we don't want to dose all 900 up front because then we risk things like respiratory depression and significant sedation. So you would dose it every 3 hours. And so 2 hours prior to your last completion of your loading dose, the third 300 milligram dose, 2 hours before it's completed, you do want to just assess and get a phenobarbital level. The point of that is to just assess for toxicity. Toxicity doses are greater than 30 micrograms, but more than likely, if you've chosen a more conservative dose, you're not going to hit that, but it'll give you some semblance of like peace in knowing that you have not reached toxicity level doses. And so you have that. So in addition to this loading dose that you're doing, you also have the option to do PRN dosages of phenobarbital if symptoms are uncontrolled. So if your RAS score is greater than or equal to 3, then you have the option to give additional doses of phenobarbital pushes. And per your institution standards, these PRN doses might be different, and you will just go based off of what the comfort level is for your institution. So at my institution, we are able to do 130 milligrams up to 4 doses if the RAS is greater than 3. And I can give these technically in a critical care setting every 15 minutes. The likelihood that you'll need to do that is probably less, but it is there for you to assess and do. But you do want to make sure you put in whole parameters for hypertension and whole parameters for heart rate in there for bradycardia. And those things are important to protect your patient. And so we have those standards. The very next day after your loading dose is done, you have your PRNs, you have the loading dose. Some people will opt to do a taper for phenobarbital. And so this taper is one of those things where now this becomes a little bit more clinical judgment than it is just protocol based. And so the half-life of phenobarbital is so long that in theory, actually, you don't necessarily even need to put your patient on a taper because it somewhat auto tapers after you give the loading dose. However, you may find that you're needing to do PRN doses. It might make sense to do a taper for a couple of days and not like the usual long 5 to 7 day protocols that we will typically outline. And so your institution will probably already have a taper schedule lined up for you. My institution does have a taper standard that we can adjust if we need to. It's not necessarily super high in dosages. It could be 130 milligrams dosed every 6 hours or 8 hours for a couple of days and then go down to every 2 hours or every 24 hours. And we would be able to stop based on when we find that the patient's symptoms are improving, their RAS scores are improving, their mental status is improving, they're no longer requiring breakthrough doses. Those are signs and symptoms that you could potentially just back off on the medications and just reassess because it's going to continue to taper. So those are some of the sort of modalities of utilizing phenobarbital in a hospital setting, in a critical care setting. And one of the things I will often get asked, or I guess I will often see that kind of muddles the picture, is that when we're utilizing phenobarbital to treat complicated alcohol withdrawal, we are not necessarily recommending to use benzodiazepines in combination with phenobarbital. And so that is something to take away as well. If you're switching over to phenobarbital, you don't really want to combine it with other sedatives because that increases risk for respiratory depression, for sedation, and it will then complicate what you're going to be doing management-wise with your phenobarbital as well. I did mention that the trend now and the literature is showing us that long-acting benzodiazepines are the treatment modality of choice for alcohol withdrawal management. In specific patients that are a little bit older with greater than 65, and that's per hospital standards, will set sort of an age bracket of when we start to see neurologic complications, age-related effects on liver metabolism, as well as patients with history of decompensated cirrhosis or acute hepatitis. We do want to be able to be mindful that the long-acting benzodiazepines, chlordiazepoxide, aka Librium, and our diazepam, aka Valium, do have metabolites that can build up in the liver because these benzodiazepines are metabolized through the CYP system. So we want to be mindful that maybe these may not be the best choices in some of our patients with liver issues and advanced age because the metabolites can then build up and then we have increased risk for things like sedation, as well as interaction with other medications and then have the potential to cause respiratory effects as well. So we have the option to use an intermediate acting benzodiazepine. Most hospital systems will have lorazepam on their formulary, which is Ativan. And so Ativan goes through gluconeridation, which is a little bit different with metabolism, and therefore doesn't cause the buildup of the metabolite products that can then cause some of these adverse events like sedation and dose stacking and metabolite stacking. So we will often utilize lorazepam if we need to for patients with decompensated cirrhosis, with acute hepatitis. And by acute hepatitis, we can reach a clinical threshold for acute hepatitis based on elevated liver enzymes. I think the comfort level of utilizing long-acting benzodiazepines with liver enzymes that are greater than normal is per provider. And that's just been my experience. I think most providers will feel more comfortable utilizing Ativan, lorazepam for LFTs that are maybe 3 times or more greater than normal. Everyone's personal threshold is a little bit different. If your patient doesn't have decompensated cirrhosis, doesn't have neurologic insults or injury, you may feel more confident utilizing a diazepam or Librium. But if you are concerned about some of this, or if they came in for something like a fall, then maybe the risks of dose stacking might cause increased risk for things like delirium and issues ambulating and things like that in a few days. So maybe you want to avoid or help reduce some of those risks by using something like an Ativan, lorazepam instead. So those are just things that I wanted to lay out there when choosing benzodiazepine.
Yes, thank you so much. That's so amazing. Just listening to you. And guys, when I do rotate with her, I'm like always trying to soak it all in because there's a lot of information that if you're not fortunate enough to have an addiction service, such as the cash team or even a clinic in your program, then you're only getting like a month worth of training. And sometimes it could be sparse. So when you get the opportunity to learn from someone like Dr. Desai, it's very important to listen. And I'm going to do a quick review of what I have gotten from everything that she said. So it's important to have a framework of what's going on. So when you get called, especially when you're on the inpatient service, as she works in the consult service, making sure you're actually chart reviewing to see what's going on, the number of medications, or what the patient has been or the person has received in the last 24 hours, how they're doing, making sure you're actually having a conversation with the primary team that's taking care of them to see what's going on. Those things are very important. She mentioned some red flags to look out for. So if someone has a history of seizures, DTs, blackouts, if they've been hospitalized for their alcohol use, these are all things to be on the lookout for. And you're going to get all this information from your chart reviewing or having a conversation with the person themselves or getting some collateral information, as she's mentioned. She also went over some of the symptoms that we may see, and she talked a lot about CIWA and what you can see. When someone is going through symptoms of alcohol withdrawal, we know like all the different symptoms that they may have. She went through like from hour 0 to when they're 72 hours in it and having delirium tremens. So just looking at starting from their anxiety, not being able to sleep, maybe they may have a headache here and there, palpitations, all these minor symptoms that then gradually may increase by hour 24. They're having these like hallucinations, whether it is audio, visual, tactile, they may have it. And these may sometimes resolve around 48 hours, as she's mentioned. And at that point, between that 24-hour mark, even 12 hours to that 24-hour mark, you are starting to see possibility of the withdrawal seizures that may come in. But when you get to that after 48 hours, 72 hours, then that's when you can see your delirium tremens. So if you paid attention, she actually said seizure, delirium tremens, trying to give you an idea of the timeline. The seizures mostly they're happening before the delirium tremens. So those are some of the symptoms that she's gone over. She talked about management, whether it is symptomatic or fixed. Some of the medications that are being used are benzos and barbiturates. So she talked about Librium and Phenobarb and how you can use those as well. The biggest takeaway out of all of this that I got was making sure you reassess. It doesn't even matter if sometimes you have to reassess within a 24-hour mark multiple times, but things can change. Patients can get better or things can get critical. So it's important to reassess and adjust your treatment accordingly. Thank you so much, Dr. Desai, for giving us that quick crash course on alcohol withdrawals. Thank you so much. I am so appreciative of you coming and teaching us all of this. Guys, listen to this over and over again. It's going to help you for your boards. It's going to help you in your clinical care. If you are a family member or someone with lived experience yourself listening to this, you can take a thing or two about some of the treatment that she talked about. If you may happen to be advocating for yourself, advocating for a family member, these are some knowledge and tools that you can use for yourself as well. So please listen again, share. We're all here to learn, including myself, and to spread the word. So please help me again thank Dr. Desai, our amazing guest for this episode, for coming to teach us. And just know you're going to see her again. I love to learn from her, so I want to share her with you all as much as she is available and allows me to. I don't want to monopolize my time. But as always, all the resources and studies that have been mentioned or any resource related to this would be in the show notes below. Thank you to you all for listening and coming in time after time. Join us next time, same place, for different discussions on things surrounding substance use and psychiatric care. And as always, stay ready, stay aware, and stay grounded. Thank you.